Hi guys, we're just going to run through how we would do a biomechanical assessment in a clinical setting. As I previously said, we need to get a lot faster at our biomechanicals and make sure it flows so we're not getting up and down with our patients and doing lots of different assessments. So we're just going to quickly run through how I would like the biomechanical assessments to flow during your consultations with your patients so that it's a lot more seamless and also so you're not wasting time, okay? All right. So first thing we've taken all our history, we've got our differentials, and now we're going to explain to our patient that we want them to, we're going to check everything now, we're going to check from their hips, their knees, their ankles, their feet, all the way down. We're going to get them lying in the bed, we're going to get them to, we're going to check some things lying down first, then we're going to check some things standing up, we're going to have a look at them walking. First thing we want to do though is check them lying down, and we just explain to our patients that please let me know if anything hurts, nothing should be uncomfortable. And that they let you know if anything is painful. So get you to lying flat first, our patient. First thing we want to do with leg length is make sure no one has anything in their pockets because that can put everything out. And just be careful with all the beds where the seam is in the bed because that can chuck hips out of range of motion as well. So we're going to get our patient to bend his knees first. We're just going to we just need to make sure the hips are centered. So to do that, we get our patient to lift the bottom up, flip back down again, lift back up again, flop down and relax. And you just give a little pull on the legs. Now here, I'm going to eyeball leg length a little bit and just see if it looks okay. You can do that in the knees bent position as well. So you can actually do that little bit of an eyeball there. So the next thing we want to do is our leg length. So we're going to get our tape measure. I usually just let the patient know. I'm going to feel your hips out, check your leg length. Always let the patient know what you're doing. Check our leg length. And I always go to the medial malleoli. I'll come on the other side so you guys can see. We check both sides. Then I ask my patient to find his belly button for me. Always just ask the patient to do it for you so you're not looking around yourself. And we check our leg length. Done. We record the results. Now we're going to go straight into hip. So I'm going to get you to bend your knee for me. Have a bit of a feel through the hip. Then we want to check our internal external rotation with flexion. In this position, I would also check hamstring while I'm here because I'm already in the perfect position for that. Okay? And we would do the other side. Now I'm going to check extension with the hip under extension a little bit later. So I'll come back to the hip internal external rotation with extension in a minute. So we've done leg length, we've done hip range. I generally have a little bit of a feel through people's knees at this point while I'm in this position as well, just to feel for any arthritic changes. I would also have a little bit of a feel on lateral medial malleoli, lateral ligaments of the knee as well, just to feel for any tenderness or swelling in that, because it can change with their gait. I would then go straight into our next joint down, which is our ankle joint range of motion, making sure we're in subtalar joint neutral. Making sure, putting a little bit of pressure and making sure we are stabilizing above and below that ankle joint so we've got good range. Again, we would do that bilaterally. You can measure. You can measure as well if you want to really get an idea what ankle range is, what 10 degrees looks like, what 5 degrees looks like. It is a good idea to measure. You can draw the lines, okay, if you need to, and you just mark the middle of the malleoli when you're doing those testing. But you've got to make sure you're in subtalar joint neutral. Record our results. Go straight into subtalar joint. I would check, am I getting that 20 and 10 degrees of subtalar joint range of motion? Does it feel, is it hypermobile? Is it restricted? Is it within normal limits? Am I getting that 20-10? Okay, bilaterally. We'll go straight into mid-tarsal joint range of motion. Again, you want to make sure, I'll do it on this side so you guys can see. You want to make sure we lock in. Want to get it into our subtalar joint neutral position before we check mid-tarsal joint. It's good to put a little bit of pull on this cap. We can check then our subtalar joint range of motion, our longitudinal and our oblique axis. okay? And we do that bilaterally, both sides. Restricted. Okay, we're going to go into our next joint, which is our first ray range of motion. Again, making sure we're stabilised, make sure we're in subtalar joint neutral position. Stabilise 5 to 2 mets, and we only want to move the first ray. Are we getting any restriction, or is it even within normal limits? Again, other side, subtalar joint neutral. Stabilise 5 to 4, and we're checking our first ray. Going into our next straight down, which is our first MPJ. I usually always measure first MPJ, mainly because we're dealing with kids. You want to see if there's any restriction, or if you're dealing with HAV or arthritic changes, you're going to monitor any progress or decline with that joint range of motion. So I would actually use this. You can actually, I don't bisect, but you can learn to bisect, and you're bisected through the first ray and through the first, and you're actually just seeing, are you getting that range of motion? Okay? Are you getting that more than 65 degrees and recording that? In this position, I'm just going to jump back. On the bioforms, it's actually written in the weight-bearing tests for malleolar torsion testing, okay? Which is the malleolar torsion, tibial torsion, how much rotation, external rotation we have from the knee to the ankle, okay? Now, in the bioforms, it's written as a weight-bearing test. That's because we didn't have the gravity gomiometers at that point, but we do now, so we can actually measure this properly now. And I would do it before I move on to getting our patient to roll over into a prone position. So you basically would mark out the medial lateral condyles of the knee. Our gravity gomiometer measures the angle. We place it on there and we get the knee to 0, okay? So we want the knee to be at 0. Then I would put the foot, making sure I've got the foot in subtalar joint neutral and I'm locking it up. And my knee is at 0, so it's not too far out, it's not too far in. Then I would actually mark out my malleoli, okay? You can bisect and put a mark in the middle of the lateral and the medial malleoli. Then we use the gravity gomiometer, place it in the middle of those malleoli, and it will give you a measurement, and it's 15 degrees, which is within normal limits, okay? So that means that the torsion, the external rotation of the tibia is sitting at 15 degrees, okay? If it's really high, you're going to get a really external rotated foot. You can get a lot of out-toeing, things like that. If it's too low, like it's down near 0 to 5, you're going to get a lot more internal rotation through the tibia, and that can cause someone to look like they're toe walking. Not toe walking? Pigeon toes, yes. Okay. Alright, so we've done all our measurements in our supine position. Now I'm going to get my patient to lie over and roll over onto the tummy for me. Now, in this position, we're going to check a couple of things. Just get the patient to come down a little bit so their feet are over the edge. Okay, I would check soleus in this position because we checked our ankle joint before and we measured for gastroc range of motion and gastroc flexibility. With the knee bent, we're now testing for soleus, okay? You should always check gastroc and soleal when you're doing ankle. You should never just check gastroc, okay? So in this position, I would now actually, you can measure again, so you're getting an idea what that 10 degrees looks like that you're trying to actually achieve. Making sure we're in subtalar joint neutral. Make sure we stabilise. And we're seeing how much range of motion we have of the soleus. Okay, and we would do that on both sides. I would check soleus. Now, I can check again. I always have a little bit of a look now. You can bisect the calcaneus and the lower limb and actually check that 2010 and have a bit of a play with your measurement here. Are you getting that 2010 under measurement? It's a good tool to use to really know what's 2010 look like, okay? As opposed to, is it 5 and 20 or is it 10 and 15? Are you getting any restrictions? So, again, you just want to make sure you're locked up And then you want to check that subtalar joint, 20, 10 range of motion, stabilize through above. Okay? And we do that on both sides. Are we getting that 20, 10 subtalar joint range of motion, and does it feel nice and smooth? Now I want to check my forefoot to rear foot position, okay? So I know I'm checking for those forefoot varices, forefoot valguses, plantar flex versus raise. So putting our foot in subtalar joint neutral again, so making sure we're in subtalar joint neutral, we're nice and straight through the back, putting a little bit of pressure on the fifth, I'm looking straight down the foot, and I can actually see if the forefoot is actually a little bit varus, a little bit valgus, or we've got any plantar flexed positions. And Kevin's got a little bit of a varus. And check bilaterally, and varus on that side. So he's probably got about a 6 degrees varus bilaterally. So we record those measurements. So we've done our promontory supine. Quick one I want to come back to, which we talked about, was our hip. So I'm just going to get Kevin to roll over again onto his back. You can do this before you roll them over, it's fine. Get Kevin to come all the way down the end for me, all the way, all the way, all the way. So our knees are hanging over the edge of the bed. If you're in a bed that actually has a folded bottom, you can just fold the bottom down, it's a little bit easier. And we want to check now with that hip. Our internal, external hip rotation, bilaterally, we're a little bit tighter in this position than we were when the hip was flexed. And we also want to check our modified Thomas, okay? So we're going to explain to our patient, we're just going to get our patient to hold onto his knee for me, and then pull it up, and we're going to check those hip flexors, okay? I will explain a little bit more about modified Thomas and what you're looking for in the test, but we just want to do that bilaterally. So you can relax that one and pull up the other one for me. Yep. And he's a little bit tighter in those hip flexors on this side. Okay, and you come back down and you can record those results. Okay, get our patient to sit up. And we're all finished with our non-weight bearing and our weight bearing tests. We would now go and do our standing tests and then our gait assessments. Okay? So the whole thing took me 12 minutes, guys. So it should only take, I don't expect you guys to take 12 minutes, but the more you practice, the quicker you're going to get. And it will be a lot more seamless, okay? A lot smoother. So practice, practice, practice is the key. Okay, bye.